Hey, Jody. How's it going? Oh, I can't hear you. Why can't I hear you? Can you hear me? You can. Okay.
Sorry, I was finishing a phone call.
Oh, there we go. Okay. I was like, why can't I?
Okay, so Cassandra's trying to log in,
Mhm.
and I guess she got worried. Hold on, let me call her so that she can log in.
Okay.
You should be able to log in now. There's somebody from HFMA yeah, so go ahead and click in. I'm in already.
Yep.
Okay, thanks, bye. Okay, so she wasn't sure. I was calling Natasha. How do I get in? How do I get access?
Yeah,
So,
normally we open it up 15 minutes prior to the start. So
got it.
Yep.
Okay. Yeah. How are you doing?
I'm doing good. How are you?
Good. Little
Good.
congested. I'm sorry if you hear me.
Oh, that stinks. I'm sorry.
The change in the weather always messes me up. So
Yeah,
it
I
is
know
what
what
it
you
is.
mean.
Yeah.
Yeah, I find it really like affects my skin. Like I get really, I'm always really dry anyways, but it's even, worse.
Yeah.
Especially like as we go from summer to winter too. So
That's my thing. When I go from summer to
Mhm.
not that we have a fall in Florida, but
Yeah.
It's horrible.
Yep. Yeah, I'm in New England, so we get all four seasons, which is
Yeah.
nice. But we don't have sunshine all day long or all year long either. So
Well, we don't necessarily have sunshine all year
No,
long.
You
but
don't?
we're lucky, Jody. You can't compare to other places. You know what? She's taking it for granted. When you live in other places, you realize that
Mm.
we have obviously our rainy days and we need them, but
Mhm.
we're lucky when it comes to the sunshine.
No, don't get me
Yeah.
wrong. I prefer, I don't want to live anywhere else. I do I'm a Miami girl.
Yep.
I love the sun, the beaches, I don't want to go anywhere else.
Yeah, I've never been to Miami. I gotta get down there.
It's
You gotta
beautiful.
come and visit.
Now, were you affected by the hurricanes at all too much, or because it kind of went,
It went to the
hooked
other
around.
to the west coast of Florida, so we really
Yeah.
didn't personally. However, like our clinics and things like that are on the west
Mhm.
coast, they did get affected.
Sorry, I'm here being very superficial and playing with my lights and playing with my hair.
Nope, you're good. That's the whole point of this. So
Not that I should be, not that I should care more about that than other things, but then I
Your hair
figure
looks
that
great.
this video will haunt me for the rest of my life. Natasha takes it much better than I do, Jody. I know. I'm a paranoid disaster.
Listen, it's different. Neither one of you take it better than the other. You just take it differently than the other.
Mhm.
No, she's a pro. She really enjoys it. It's totally different.
She is a born presenter.
She loves it.
Definitely is.
She literally enjoys the whole, I don't know, excitement and doing it. I have a nervous breakdown each time, no matter what. I look much better than what I'm feeling. I guarantee that's the only good thing.
Mhm.
Let me get the other light on. I'll be right back, ladies.
Okay. Now, Jody, you're going to be handling the polling.
Yes, ma'am.
Do you need to review that, or are you all set?
No, I did it for Natasha
Okay.
already once before. So as long
You
as
remember how to trigger them and everything?
as I have host access to
Yep,
be
you
able to
should.
do that.
So we're in a meeting. We're not in a webinar. So yeah, you have the access, so no issues.
Let me see.
Do you see at the bottom the little polling thing?
I don't.
Okay, let me give you access.
Because it's usually like some little bars, and then you touch that and it'll click you to the.
I'm listed as not a host. So you're the only one that's listed as a host. Okay, I don't even see you as a host.
But I don't see the bar. That's why I was asking, because I did Natasha's at the last meeting and she was able to.
Now I'm the co-host. Hold on. I don't know what just happened.
That's me. I'm doing that.
Oh, okay.
Sandra, I'm giving you co-host.
Oh, I see it too. Perfect.
Privileges
All right.
as well.
I know you can't stick around today, right? Because they told us that you wouldn't be able to. Am I correct or no?
Yeah, we're in a conference.
I know. So
we
don't
can-
worry, I understand. We just wanted, and thank
Yeah.
you for logging in because I was
no
using the
problem.
login they gave me last time and it wasn't working and I was like super nervous. I was like, oh my God, I know the password changes every so often and I'm like, why didn't I check before? Oh, no, but it was great that you joined. Thank you so much.
Oh, no problem. Yeah, so Jody, so can you see the polls as a co-host? You can. Okay.
Yes, now I
So-
see it.
Okay, so Jody, I'm gonna make you the host before
Okay.
I leave.
Okay,
So you'll have, all the capabilities, but I believe you have the same capabilities as host anyway.
yes.
Okay, do you have a presentation you wanna?
Yes, I'm gonna go ahead and start sharing the screen.
Okay. And right now we're in a meeting, so we're not in a webinar. So the only thing is that the difference between a meeting and a webinar is that the attendees can turn on their camera and turn on their microphone when you're in a
That's
meeting.
fine. So during the ground rules, I pretty much tell them, let me go to my ground rules to make sure before I assume.
Mhm.
Sorry.
Yeah, that
just
looks great.
reading it. Oh, thank you. You're seeing the proper screen. It looks even to both of you ladies and everything. Okay.
Yes.
So in my notes, I let them know that the session's being recorded and I will, therefore I ask that you please remain on mute and off camera during the session. You may ask questions during the session utilizing the chat feature, and you may also ask questions at the end of the session. Just turn on your camera and remove yourself from mute to ask questions.
Yep.
So I'll let them know up front.
Perfect.
So, I mean, it is also an option, like I can remove their capabilities.
You can,
Yeah,
if
but
you
I mean,
want
I
to.
don't think they
Oh, okay.
really, we've never had problems. Most people are really quiet and trying to take notes or what have you. Like, and the questions have been like legit questions. It's not even like bombarded with, I was very nervous at first thinking, oh my God, they'll have a million questions, but no, it hasn't been bad. So I don't anticipate that. Now, the only thing is, with when to trigger those poll questions, Jody?
It comes up in your slide. It usually
Okay, so
says,
when you see it there,
Mhm.
you'll do, okay.
Mhm.
And also, Cassandra, what I usually do for our national webinars, when we do have poll questions, I usually have the speaker just announce we have our first poll question.
Yeah.
And
No,
then
no,
also
I'll tell
kind of
you.
trigger to Jody to launch it. Also, usually if they have to get it for their CPE credits, sometimes they're not always watching, sometimes they're multitasking. So kind of announcing that we have a poll coming up just, makes them hear it. So I just find that helpful to do that.
No, not a problem. I'll do that. I was just for her to know, because I've been busy on the chat, not knowing that and then you're like scattering. So I try to mark the slides just so that I'm kind of ready for when it comes. And then the other question that I had is the recording.
We're already recording.
Oh, we are. Okay.
Yes. Yeah.
Perfect.
And we can remove this part.
Okay, perfect.
for
Thank you so much.
Yeah. So
All right.
this won't be in the recording.
I know we've got a couple of people, but I'm gonna wait till like 5 minutes prior, and then I guess I'll keep my camera off and Jody will turn hers off and then we'll get started.
Okay. All right. That sounds good.
Don't get scared if you see the slides changing. I'm just reviewing them real quick, okay?
Yeah. No worries. Yeah, and Jody, you also have the ability to mute
Participants. Yeah.
participants too. Yeah.
Okay. Perfect.
So I think I'm almost positive you have the ability to turn off their camera too.
I do. It says it here. I
Yeah.
have that capability too.
Yep. Okay, great.
Yeah.
How's your conference going?
It's going good. Yeah, it's
All
basically over at this point. So
Oh,
just a couple of last minute meetings and things like that. So
no,
yeah.
but glad to hear that's going well.
yep. And then off to the airport.
Well, feel free to drop whenever you're more than welcome to stay, but I know you're busy and I know how it is that like 50 things come up. So don't feel obligated to stay with us. I know
Okay.
we know the drill, so don't worry. Okay.
Okay, good.
And thank you very much for joining and
Oh,
helping
no
us.
problem. Yeah, that's what we're here to support you guys. So
Thank you.
yep.
Just reviewing the last ones, Jody, and then I'll move the presentation before we admit anyone. I just didn't make it to the end very much. And I think when I read it, it just rolls off the tongue better later than going in blind.
Yeah, I mean, we can wait until, what, 11 o'clock if you want to
Yeah,
open it
let's,
up,
because we're
or,
already recording. So what I'll do is I'll start right at 11 and then I'll just welcome everyone and we'll get right
Mhm.
into it. Because usually I open a little ahead and I say we're gonna wait for more participants, but no, I think since we're recording, it'll be smoother to just
Yeah.
start right on time.
okay,
Thank you.
all right, that sounds good.
Definitions are really good. So 6. I don't remember ASC. I'm Googling it. That'll- ASC is the appraisal subcommittee, I believe. Federal oversight of state appraiser. Appraisal subcommittee, yeah. Just in case someone asks, I always like to anticipate questions.
Mm-hmm. Oh, yeah.
Never know.
Nope.
All right.
Yeah, and Jody, I'll stay on for a couple of minutes and then I'll IM you, or I'll send you a message in the chat directly
Okay.
before I
Perfect.
transfer you host and make sure you're all good to go.
Okay, thank you. I'm happy that I'm not the one talking the way that I sound right now.
You know, it's those times where you appreciate breathing, like through your nose and stuff, you know?
It's so true.
So
Oh my goodness.
I know. It's the small things.
And I'm happy that I can turn off my camera in case I have to blow
Mm-hmm.
my nose or something. Like it's just,
Mm-hmm.
so
Yep, I get it. We
I
all
will
get it.
gladly do the polling questions.
Thanks a lot.
Sorry, Kay.
Now my nose itches and I'm all on edge. All right. You know what I wish, like for the next PowerPoint version, they need to flip the slide and the reading so that I can read here and it'd be more like looking at the camera.
I
than read
know,
at
like
the-
up above.
And I've tried
I
the two
agree.
screens, but no matter what, the camera is always like when you're looking at two screens, it doesn't work as well. So I wish
Mhm.
that they would let us flip the notes with the The PowerPoint. Next time,
Yeah.
right?
Yep. Okay, it's 1 minute to go. I'm gonna turn my camera off,
All right.
just so I don't forget to do that.
Okay, me too.
So it was nice meeting you both,
Thank
Likewise.
you. Likewise.
and I'll let you know right before I admit everyone.
Perfect. But I'm ready when you are, okay?
Okay. All right, it's 11 o'clock, then we'll let everyone in.
Good afternoon, everyone. We have a couple of folks connecting to audio, so I'm going to give it just 1 more minute. Welcome and thank you for joining us today for the CRCR Certification Series course. Today we will be covering the second part of Unit 1. My name is Cassandra Lage, and I'm a member of the Florida HFMA Certification Committee. I work for the Sylvester Comprehensive Cancer Center, which is part of the University of Miami Health System, as an executive director of patient access, and I've been with the University of Miami for 17 years. I earned my MBA from the University of Miami, as well as my undergraduate degree, my Lean Six Sigma Green Belt, and Champion Belt. I also hold HFMA's CHFP certification, and I'd like to review a few of the housekeeping rules and some reminders. Be sure to complete the online coursework along with attending these sessions. Attending these sessions alone is not sufficient preparation for the exam. This session is being recorded and will be available on the HFMA YouTube channel. Since the session is being recorded, and I'm going to ask that you please remain on mute and with your cameras off during the session. You may ask questions during the session utilizing the chat feature, and you may also ask questions at the end of the session. Just turn on your camera and remove yourself from mute to ask any questions. Today, we're going to be covering the second part of Unit 1, which is 1.6 through 1.10. In section 1.6, we're going to address specific Medicare compliance and coding issues, and we'll be covering terms such as the MSDRG window, the Tune Midnight Rule, correct coding initiative or CCI, modifiers, and Medicare secondary payer or MSP. Programs, compliance programs highlight the key risk areas in billing. A comprehensive plan along the lines suggested by the OIG or the Office of Inspector General indicates that an organization is serious about being compliant with regulations and may serve to keep the federal government from dictating a plan for it. It will also insulate the hospital from violations of false claims or fraud and abuse regulations. And I have here listed some of the bullet points. Purpose of a compliance program is to create a program that is transparent, clearly articulated, and emphasize that all employee levels as a seriously held personal or an organizational responsibility, one that relies on full communication inside and outside of the organization. Please note that the essential elements of a compliance program are tied to the organization's program and policies. That's why copies of the policies and procedures are shared and then reviewed. There's basic things to keep in mind regarding the 3-day window rule. Any non-diagnostic outpatient service is considered related to the admission if it uses the same ICD-9 diagnosis code as the principal diagnosis for the hospital admission. All diagnostic services and related charges provided within the window are considered to be related. These include radiology, cardiology, clinical laboratories, EEGs, pulmonary function tests, and audiology tests. Related charges include anesthesiology, drugs used to provide radiology or other diagnostic services also. Services are considered to fall within the window if they are dated within 3 days before the date of the admission or on the date of admission. For example, if the admission is on a Wednesday, any services provided on Sunday, Monday, and Tuesday and before the time of the admission on Wednesday are all within the billing window. Ambulance, dialysis, and Part A services provided by a nursing home are not considered related. Since the beginning of the Medicare program, certain payers have always been liable for payment of claims. More recently, with the enactment of the Medicare Part C or the Medicare Advantage Plan option, this principle has been expanded to include work-related injuries and accidents, in other words, your workers' comp claims, Black Lung Program services, Veterans Affairs services, patients' enrollment in a Medicare Advantage plan, federal grant programs, and public health service programs. In these cases, Medicare does not make a secondary payment. The amount is paid by the primary payer and are considered payment in full. In recent years, the OIG has been reviewing these claims in order to ensure compliance with the MSP rules. So what are the Medicare secondary payer situations? I'm going to go ahead and define each one of these bullet points for you. The working aged is that the patient's age is 65 or more, or their spouse, and they're employed or their spouse is employed, and under a group health plan, which is, you're going to see abbreviated as a GHP. And that group health plan coverage is through the workplace, and the insurance provided by and GHPs are provided by employers that have 20 or more employees. If the employer has less than 20 employees, the GHP does not qualify as a primary payer, and Medicare should be billed as primary. The patient's not required to accept the employer's insurance coverage. And again, Medicare would be their primary. And the employer is prohibited from offering a supplemental policy in place of the standard group health plan benefits offered to other employees. So they still have to offer just a regular health plan. Next bullet point is accidents or other liabilities. When the patient needs medical care as the result of an accident, the liability insurance company may be responsible for payment. Automobile accidents as well as premise accidents are included in the MSP category. Healthcare providers are required to obtain the billing information from the liability carrier. The liability is prime only if the accident did not occur on the patient's own property and if the patient states that there is a liability. Required coding on the UB04 includes the occurrence code and the date of the accident. If no medical payment or other third-party coverage exists, occurrence code 05 and the date of the accident or injury must be provided. Disability. The patient's eligible for Medicare due to a disability if the patient's under 65 years of age and has group health insurance coverage through a large group health plan or an LGHP. An LGHP is a group health insurance plan provided by an employer that has 100 or more employees. If the patient or their spouse is currently employed, has employment with that employer, And if the employer were to have less than 100, it would then be a GHP, and that does not qualify as a primary payer, and Medicare should then be billed as primary. Then our last bullet point is the end-stage renal disease. The patient has permanent kidney failure, is covered by a GHP, and has not completed the 30-month coordination period. Please note that after the completion of the 30-month coordination period, Medicare does become the primary payer unless another MSP condition exists. So the insurance must be a qualifying GHP, and again, the patient must be within the 30-month coordination period. The Medicare program pays only for medically necessary services. Therefore, providers are expected to screen outpatient services for compliance with Medicare coverage rules. If an ordered service does not meet medical necessity based on the test and diagnostic information provided, the provider is required to issue the appropriate advanced beneficiary notice, or ABN. An ABN must follow the wording provided by CMS to ensure that the text is easily understood, clearly identify the specific test or services identified as non-payable, provide the information used to determine that Medicare may not pay for the test or service previously identified, provide the information used, be provided to the patient far enough in advance to allow time for the beneficiary to make an informed decision, be understood by the patient or the patient's designee, and last but not least, comply with the use of the form provided by CMS for this process. Then we have the 2-midnight rule. Traditionally, the decision to admit a patient as an inpatient has been up to the judgment of the treating physician with oversight from the hospital and input from the patient. CMS recovery audit contractors, or RACs, RACs, we often refer them to as RACs, and Medicare administrative contractors, or MACs, had a tendency to second-guess physician judgment, declaring that some patients who were admitted should not have been admitted. This has created an ambiguity over who decides what constitutes an appropriate admission and what the criteria is for making such a determination. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, the Centers for Medicare and Medicaid Services, or CMS, developed the Correct Coding Initiative, or CCI. The purpose of the CCI is to ensure that the most comprehensive groups of codes rather than the component parts are billed. The program consists of edits that are implemented within providers' claims processing systems. The CCI edits are incorporated within the outpatient code editor. The edits also check for mutually exclusive code pairs. The unit of service edits determine the minimum allowed number of services for each healthcare common procedure coding system, or the HCPCS. And using a modifier allows a hospital to indicate a specific circumstance that has affected a procedure or service without changing its definition or code. The appropriate use of modifiers reduces the need for separate procedure listings on a bill by describing the modifying circumstance. So as we move on, please keep in mind the following key points. The 3-day DRG window rule requires certain outpatient services that are provided within 3 days of the admission date by hospitals or by entities wholly owned or controlled by hospitals to be billed as part of an inpatient stay. The purpose of the ABN is to inform a Medicare beneficiary before he or she receives specified items or services that might otherwise be paid for, that Medicare certainly or probably will not pay for those items or services on that particular occasion. The situation where Medicare acts as a secondary payer includes working aged, accident or other liability, disability, and end-stage renal disease. In order to promote the use of correct coding methods on a national basis and prevent payment errors due to improper coding, the Centers for Medicare and Medicaid Services developed the CCI or the Correct Coding Initiative. The purpose of the CCI is to ensure that the most comprehensive groups of codes rather than component parts are billed. And so now that we've had that recap, we're going to go ahead and get to our first polling question. I really, really encourage you to answer the question, because even if you get it wrong, you're more likely to remember it when the test comes. So in order to promote correct coding, CMS developed what? All right, and everyone replied, so thank you for participating. I appreciate that. And the answer is A, the correct coding initiative. And every single one of you got that correct. The purpose of the CCI is to ensure that the most comprehensive groups of codes rather than the component parts are billed, and the program consists of edits that are implemented within the provider's claim processing systems. The CCI edits are incorporated within the outpatient code editor, and the edits also check for mutually exclusive code pairs. This brings us to section 1.7. In this section, we will address business or organizational ethics, the application of ethics in healthcare, and the revenue cycle. So why talk about ethics? Our society is changing at a rapid pace. I think everybody can agree on that. And we're expanding, the global economy is expanding, workplace diversity is increasing, there's expansion of the information highway, there's increased technology, unique generational differences, and as a result, defining and applying ethical business practices and principles is important to every single industry. Healthcare services are important to both individuals and our society, and as a result, healthcare providers and those that work in the healthcare industry have additional ethical duties to the patients and communities that they serve. Examples of ethic violations which may occur that impact the revenue cycle include financial misconduct, overcharging, theft of property, falsifying records to boost reimbursement, miscoding claims, and provider policies and procedures should be, and privacy violations. Provider policies and procedures should be in place to reduce the risk of all of these listed violations. However, it is just as important to be aware that an individual's experience and value systems may impact his or her actions and result in non-compliance. Patient privacy is an important standard within healthcare, more specifically a patient's protected health information, or PHI, and it's addressed in standards for privacy of individual identifiable health information, or what many refer to as a privacy rule, within the Health Insurance Portability and Accountability Act of 1966, commonly referred to as HIPAA. Employees of providers are required to learn and apply proper procedures to ensure protected health information is secure. However, based on an employee's experience and value system, the employee may not believe his or her actions violate the PHI standards. Thus, business ethics can be violated by an employee due to the lack of awareness rather than any malicious intent. Nonetheless, this ties into the importance of having policies and procedures in place that are detailed, that explain everything, and ensuring that they're shared with all employees, right? Because employee education is very important. So some key points are business ethics or organizational ethics represent the principles and standards by which organizations operate. Business or organizational ethics are relevant to the conduct of individuals within an organization. We also reviewed some of the examples of ethic violations, which included financial misconduct, overcharging, theft of payment, falsifying records to boost reimbursement, and miscoding claims. Other points to keep in mind include that ethical behaviors, which is considered to be actions that are the right thing to do, not just what is required by law or the regulations or rules, is very important in healthcare. The concept of ethical standards applies to actions that are hoped for and expected by each individual staff and management member within healthcare. And it's important for staff and management to uphold the business ethics of the provider and act as peer role models. So this brings us to a polling question. What do business organizational ethics represent? All right, and everyone selected again the correct answer, which is A, principles and standards which organizations operate. In healthcare, both clinical and financial personnel must be fully aware and engaged in the laws and regulations that govern their work. Businesses or organizational ethics are relevant to the conduct of individuals within an organization. Great job. And now we're beginning section 1.8, volume to value. And in this section, we're going to be addressing the board provisions of the Affordable Care Act, ACA, of 2010, CMS's proposed alternative delivery and payment models, and standard quality measures. So the Patient Protection and Affordable Care Act of 2010, also known as the Affordable Care Act or ACA, was passed and signed into law in 2010. It was designed to reform the healthcare system into a system that rewards greater value, improves the quality of healthcare, and increases efficiency in the delivery of services. It included provisions to improve the quality of care, reform the healthcare delivery system, encourage price transparency and modernized financial systems, and address the issues of waste, fraud, and abuse. And there are more details about the ACA on the online course. So as you go doing the CRCR online course, you'll see more information on this. Over the next 10 years, these improvements will not only improve the quality of care provided, but also reduce Medicare spending by more than $15 billion. Another cost-containing provision of the ACA is reforming the healthcare delivery system. Reformation of the healthcare delivery system includes established regulations for the development and financial accountability care organizations, or ACOs, and developing new approaches to payment and delivery systems through the Center for Medicare and Medicaid and Innovation. The Center for Medicare and Medicaid Innovation is charged with the ongoing development of new models for delivery and payment of services. Targeted innovations involve quality improvement and/or increases to efficiencies that could be expanded throughout the healthcare system. An accountable care organization, or an ACO, is a delivery system of physicians, hospitals, and other healthcare providers who work collaboratively to manage and coordinate the care of a patient population. The point of this collaboration is to ensure appropriateness of care, elimination of duplicate services, and prevention of medical errors for a population of patients. Examples of various ACOs are listed that are currently being tested. Volume to value. So hospital value-based purchasing is a CMS initiative that rewards acute care hospitals with incentive payments based on how closely best clinical practices are followed and how well hospitals enhance patient experience of care during hospital stays. Hospital readmission reduction program. CMS is required to reduce payments to hospitals with excessively high rates of avoidable readmissions. And the physician quality reporting provides financial incentives to physicians for reporting quality data to CMS. In 2015, incentives were eliminated and Medicare payments were reduced for those physicians who did not satisfactorily report quality data. CMS used learnings from the first BPCI models to launch the Bundled Payment for Care Improvement Advanced Model, or BPCA CIA, in 2018. BPCI Advanced operates under a total cost of care concept in which the total Medicare fee for services, spending on all items and services furnished to a beneficiary during a clinical episode, including outlier payments, will be part of the episode expenditure for purpose of the target price and reconciliation. The comprehensive care for joint replacement model aims to support better and more efficient care for beneficiaries undergoing the most common inpatient surgeries for Medicare beneficiaries. Hip and knee replacements, or they're also called lower extremity joint replacements, are amongst those common inpatient surgeries. The standardized quality measures are a critical component of the CMS initiatives. Quality measures are tools that help us measure or quantify healthcare processes, outcomes, patients' perceptions, and organizational structure and or systems that are associated with the ability to provide high quality healthcare and or that relate to one or more quality goals for healthcare. And to review a few key points, an ACO is a delivery system of physicians, hospitals, and other organizational health or other healthcare providers to manage and coordinate the care of a patient population. The ACA was designed to reform the healthcare system into one that rewards greater value, improves the quality of care, and increases efficiencies in the delivery of services. CMS has set a target of moving Medicare payments from volume-based to value-based payments and increasing the types of alternative payment models, which include value-based payments. And last but not least, quality is an integrated part of the changes involved in the volume to value initiative. Now we're going to have a polling question. What is the intended outcome of collaborations made through an ACO? Okay, so the group is split on this one, and I can see why. I think this was a tricky one. Letter C looks correct, but the correct answer is A. By meeting established benchmarks for quality and efficiency, participating organizations may receive a share of the savings generated by reducing duplicate services, improving productivity, minimizing paperwork, and other cost efficiencies. Around that one was A. Dwelling just a minute because I know some of you like to take notes on the practice questions. Okay, so we've reached section 1.9, financial overview. And in this section, we will be addressing the various financial reports governed by a number of regulations defined by various boards and commissions, gross revenue, net revenue, and calculations used to determine amounts for reporting. The purpose of financial reports is to present information that may be used by others to make determinations regarding the financial status of an organization. Financial reports are governed by a number of regulations, including those defined by the Securities and Exchange Commission, the Financial Accountability Standards Board, and generally accepted accounting principles. We have here defined the income statements, balance sheet, and cash flow statements, and kind of what falls under them. In accrual accounting, revenue is recorded when it is earned to permit the alignment of revenue with the associated expense. Healthcare providers generally use accrual accounting. Cash accounting records revenue when the payment is received. We have here the definitions for accrual, cash, and fund. To accurately report revenue, a provider must be able to calculate the difference between the gross revenue and the net revenue. And we have the definitions. The gross revenue is the total charges entered for all patients for the service they received. And then your net revenue, I know it says new revenue, sorry about that. It should read net revenue, is the estimate of dollar amount of contractual discount or other allowances against the gross revenue. To determine the net revenue, financial services must estimate the dollar amount of contractual discount or other allowances that will be applied against those revenues. With the implementation of ASC 606 change to the accounting rules governing the calculation of net revenue, revenue cycle may continue to use the terminologies of contractual adjustments, bad debt, and charity, but the finance terminology and methodologies will be changed. These changes are reflected in a change in financial statement presentations concerning net revenue. ASC 606 creates two types of adjustments to incurred charges: explicit price concessions and implicit price concessions. Bad debt and charity care are actually, although in both cases, a bill's not being paid, they're different. Bad debt represents the portion of the patient liability which cannot be collected from the patient. These amounts represent a failure to pay and not necessarily an inability to pay on part of the patient. Charity care represents care provided to a patient who does not have the ability to pay for services or the portion of the services rendered. And as we move on, please keep in mind the following key points. In order to report a provider's revenue accurately, it is important to calculate the difference between gross revenue and net revenue. To determine gross revenue, the charges for all the services that a patient has received is totaled. To determine net revenue, financial service estimates the dollar amount of contractual, discount, or other allowances that will be applied against those revenues. And we have a polling question. Which of these statements describes the new methodology for NPR? These are long answers, so I'm going to afford you some extra time on this one. We're going to give it one more minute. All right, we'll go ahead and share those results. So the correct answer is C, and this was a tough one. So net patient service revenue is now defined as the total incurred charges less the explicit price concession, less any applicable implicit price concessions as applied to the specific portfolio of accounts. And we've reached our final section, 1.10, key performance indicators. In this section, we will be reviewing key performance indicators, which are often referred to as KPIs for short, and benchmarking and revenue cycle management. We'll also be covering the various techniques used to measure revenue cycle management. The hospital and system MAP keys are strategic KPIs that set the standard for patient-centric revenue cycle excellence in the healthcare industry. It's developed by industry leaders and led by HFMA. These industry standard metrics represent the revenue KPIs. The keys define the essentials of revenue cycle performance in a clear, consistent, and unbiased manner. Key performance indicators set standards for accounts receivable and provide a method of measuring the collection and control of accounts receivable. Benchmarking is used to compare key performance indicators in an organization to an agreed upon average or expected standards within the same industry. There are some key benchmarks that should be used to analyze AR within a provider's organization. We're going to go ahead and I'm going to define some of the general KPIs. Days of revenue in receivables are also known as AR days. This measure is widely used throughout the healthcare profession to measure how fast receivables are collected. Industry standards for AR days are available. AR aging analysis. Aging reports divide the accounts receivable into 30, 60, 90, and 120 days, and over categories based on the date of service or discharge, if it's an admission that spans over several days. The AR may also be aged from bill date. However, this presentation completely masks the impact of any processing delays that occur between completion of the service and production of the bill. It's important to age from date of service to understand the impact that timely billing or lack of timely billing has on collection of accounts receivable. And then discharge not final billed, or DNFB, is the portion of the accounts receivable that identifies charges for patients where services are completed, but the healthcare facility has not been able to bill the claim. There are a number of activities that must be completed before bill submission can take place. These include the completion of all charging, final medical record coding, and could include insurance verification activities as well. We have a few more of general KPIs. Cost to collect, because healthcare is not typically a cash upfront business, there is a cost to collect for services rendered. This cost is calculated by dividing the total patient financial services operating expense by the gross patient care collections for the same period. Patient financial services expenses must also include admitting and registration. Cash collected as a percentage of net revenue. This key performance indicator is also known as a net collection rate. It lets you know how much actual cash collected as a percentage of what was available to collect. It is the ratio of cash to net revenue. As a percent of net revenue. Less than 2% of claims should be denied on the first submission. And credit balances or days outstanding. Credit balances should be resolved timely and should be benchmarked at under 1%, at less than 1% of the days outstanding in the accounts receivable. So key concepts from this section, the key performance indicators set standards for accounts receivable and provide a method of measuring the collection and control of ARs. The days in AR are calculated based on the value of the total accounts receivable on a specific date. AR day calculations can also be done for specific payers to evaluate the collection efficiency and the payment progress on third-party payers or on self-pay patients. And completing an analysis of AR aging and KPIs can help identify issues and areas for improvement for any healthcare organization. And this leads us to our final polling question. What are KPIs? All right, and everyone's torn between A and B. I have here that the correct answer is A. Benchmarks are actually derived from KPIs, which in turn set standards for accounts receivable and provide a method of measuring the collection and control of AR. The correct answer is key performance indicators. Sorry, my apologies. The correct answer is key performance indicators, which set standards for accounts receivable and provide a method of measuring the collection and control of AR. So B is the correct answer. I stand corrected. B is the correct answer. Okay, that brings us to the end of our review for today. So I want to go ahead and open it up to questions. If anyone has any questions, you're still able to use the chat if you'd like, or you can turn on your camera and unmute yourself and ask the question that way. While we wait for questions, I want to remind everyone to please make sure that you complete your online coursework, as these sessions do not cover 100% of the material, and usually the best results on the test come from doing both of these in conjunction with one another. Okay, so we've got a question about the past one. So this one just this new session just started, so you've only missed one prior to this one. If you go to the HFMA YouTube channel, you'll be able to see the whole presentation there. We don't provide the actual slides. We provide the presentation where you can kind of be on the YouTube channel, you can review the whole presentation, but we don't have a method of just sending you out the slides, sorry. You can go to access the online content. You can go to the HFMA website. Yes, sorry, you answered that question. Yes, you're correct. It's through there. Make sure you log in though. I'll give it just 1 minute. Those of you saying thank you, you're very welcome, and thank you for joining today. I hope you found this review helpful and useful. And I'm gonna stick around just 1 more minute to make sure that there's no last minute questions. But for those of you dropping off, I hope you have a good rest of the day, and thank you.